Everyone, in this video of mine we'll be talking about some image based diagrams, and since this is the first video of this series, so I'll just be discussing with one retinal pathology. Right, so you have you are sitting in your OPD and you have a patient, an old age patient who comes with or without any history. Old age patient like maybe 50 or 65 year of age, with or without history of hypertension, diabetes mellitus, hyperlipidemia, or any history of smoking. In females, there's a history of OCP use. Patient or your prior patient who is diagnosed as a history of who has a history of glaucoma or chronic dehydration, present with sudden painless onset of blurred vision and metamorphopsia. You examine the anterior segment, cornea is clear, lens is, there is no cataractus changes, so the anterior segment is within normal. So you examine the retina. What you see, there is dilatation and tortuosity. Now this is the affected venous segment. So there is a bit of dilatation and tortuosity of the venous segment when we have a flame shaped. See, these are the flame shaped. These are the flame shaped, and these are the dot plot hemorrhages with the cotton wool spots. So this is a spot diagnosis. The clinch the diagnosis is this is a case of branch retinal occlusion. So a bit discussion about, or a bit knowledge about that how the arterial and the venous supply of the retina. The heart aorta arises. This is the carotid artery. From this arises the posterior ciliary artery, which pierces the sclera. It goes inside the eye. After the origin of the posterior ciliary artery arises the central retinal artery, which enters in the optic nerve along with the central retinal vein, and it goes inside the eye and the supplies. Similarly, the central retinal vein, it drains the eye. One of its branches anastomosis with the angular vein and drains in the facial vein, and then the other branch, it forms the ophthalmic vein, which goes to the cavernous sinus and then to the heart. Right, so this is basically the uh, supply of the eye. All right, and the intraocular pressure is about 10 to 22 mm of mercury. So what exactly is a branch retinal vein occlusion? See, the superior temporal quadrant is most commonly affected. The site of occlusion is generally an arteriovenous crossing point. Now I'll tell you the reason that why this occlusion occurs only mostly at the site of the arteriovenous crossing, and the acute features of it is usually resolved between 6 to 12 months, right? So what happens in branch retinal vein occlusion? There is an arteriosclerotic thickening of the branch retinal arteriole, and this is associated with compression of a venule. See, this is the artery, right? Or this is an arteriole. This is the crossing point where the vein is crossing it. Okay, now what happens is there at this point of crossing, see, this is the point of crossing, so there is a common adventitial sheath which covers this artery. This is the artery, right, and this is the vein. So at the point of crossing there is a common adventitial sheath. So what happens is there is a thickening of the branch retinal arteriole. This is a thickening. This thickening occurs because of the arteriosclerotic changes, which is exacerbated because of hypertension. So this thickening, it compresses the venule, and this occurs mostly at the site of the arteriovenous crossing point. Now this compression of the venule leads to secondary changes, which includes the loss of the endothelial cells. There's a turbulent flow and the thrombus formation. That is like we had about the virtues tried. So since we have learned a bit about the pathophysiology, what all investigation you will do in a patient when you have made a diagnosis of retinal vein occlusion? You'll measure the BP. You'll measure because blood pressure causes the arteriosclerotic changes. You will measure the ESR or the plasma viscosity, which are the like thrombotic factors. You will do a full blood count, a random blood glucose and cholesterol levels, total and high density cholesterol, and a plasma protein electrophoresis. This is for dysproteinemias. Okay. right? So this is for dysphemias. Now you have made a diagnosis, how to manage. See, the first thing is observation. Observation is usually indicated if visual acuity is 6 by 9 or better, or if it is slightly worse than that, like it is 6/12, so it is improving. Only then we will observe the patient. Otherwise, we will do a fluorescein angiography at 3 months if the visual acuity is 6/12 or worse. If there is a neovascularization elsewhere or neovascularization of disc, so we will immediately go for a sectoral photocoagulation, because neovascularization means there is too much of v, VEGF which is being liberated by the retina into the vitreous, because if it and this new vessels, they will like eventually bleed and give rise to vitreous hemorrhage and hell lot of complications. The most common cause of visual loss because of BRVO is the macular edema. This edema at the macula. This edema at the macula is the most common cause of visual loss. So what we do for that, intravitreal anti-VEGF agent for the treatment of macular edema secondary to BRVO, and they raise the visual acuity more than laser. Grid laser was like previously used, but now anti-VEGF agent are a good option, right? So in my next video I'll be talking about the CRVO. Till then, happy studying.